need capacity building to our healthcare providers. There is need for resources for screening. I was first diagnosed with HIV. That was in the year 2000 when I was pregnant of my son. That's when I was diagnosed with HIV. I was facing so many challenges, in terms of my health. So doctors felt that I may need to go for HIV testing. There were no policies then, so they never consulted me. They never told me. They just did it behind. When they came in to tell me that I was HIV positive, I was shocked because then HIV was something that we could not talk about. And then they just blurted out in telling me I was pregnant, and the doctor just came in to say, Deidre, you are HIV positive. And then during that time, we are talking of 1999, there was no policy like test and treat, like you test and treat as it is of now. So I waited until my CD4 count was so low and my viral load was so high. That's when they started the ART on me without counseling. I never disclosed to anybody, not even my husband, not even my mom, not even my parents. I struggled on my own until my son was born. So several years later, when my son was 8 years, in 2008, that's when I tested positive with cervical cancer after I struggled as well. My perspective right now is that you can survive. You can survive after testing positive to HIV, and also after testing positive to
We're facing some technical challenges. Is Priscilla, is everything going okay?
Hi, Benda. Yes, everything is going on well. Let me replay the video again.
Okay.
there is need for capacity building to our healthcare providers. There is need for resources for screening. I was first diagnosed with HIV. That was in the year 2000 when I was pregnant of my son. That's when I was diagnosed with HIV. I was facing so many challenges, in terms of my health. So doctors felt that I may need to go for HIV testing. There were no policies then, so they never consulted me. They never told me. They just did it behind. When they came in to tell me that I was HIV positive, I was shocked, because then HIV was something that we could not talk about. And then they just blurted out and telling me I was pregnant, and the doctor just came in to say, Deidre, you are HIV positive. And then during that time, we are talking of 1999, there was no policy like test and treat, like you test and treat as it is of now. So I waited until my CD4 count was so low and my viral load was so high. That's when they started the ART on me without counseling. I never disclosed to anybody, not even my husband, not even my mom, not even my parents. I struggled on my own until my son was born. So several years later, when my son was 8 years, in 2008, that's when I tested positive with cervical cancer after I struggled as well. My perspective right now is that you can survive. You can survive after testing positive to HIV, and also after testing positive to cervical cancer. The most important issues, to my perspective as a cervical cancer survivor, is the need for screening, early screening. If there would be political will to put in resources to address or to come up with interventions to address issues to do with cervical cancer. You cannot treat cervical cancer without resources. You cannot talk of screening without resources. You cannot talk of vaccines without resources. What I would like to see in the next 6 years, 4 years later, 10 years, is elimination of cervical cancer. It's possible to eliminate cervical cancer.
Good afternoon, everyone. Welcome to today's unveiling. I'd like to invite Maud, who's our moderator for the day. Maud, you can take over from here. Thank you.
Thank you very much, Jackie. So, good morning, good afternoon. Can you hear me?
Yes, we can hear you, Maud.
Okay, thank you. Good morning, good afternoon, good evening, and a warm welcome to everybody to this important session. As already introduced, my name is Maud, and I'm the steering committee. I'm a steering committee member of the African Cervical Health Alliance, and I'm based in Malawi. So we are here to commemorate the milestone of the ACHA Aspire Scorecard in honor of the Global Cervical Cancer Elimination Day of Action, which falls on the 17th of November. So initially we intended to meet on the 14th of November, and it just happened that there were some other engagements and we're not able to do that. So it was set for today. So we're delighted to convene this afternoon to keep the momentum of the global cervical cancer elimination movement alive. So a bit about ACHA. ACHA is a powerful network of grassroots civil society organizations across Africa. And the intention is to eliminate cervical cancer across diverse African geographies. And we envision an Africa free of cervical cancer. So let us remind each other that cervical cancer is preventable, yet it remains one of the deadliest cancers affecting women on our continent. So together with our partners, we have spent 2 years crafting the Aspire Scorecard. This tool drives accountability by helping countries track progress, identify bottlenecks, and mobilize action on national priorities. So today spotlights the ACHA Aspire Scorecard, which tracks progress towards the WHO targets, which is 90-70-90, specifically through a civil society-led lens. So a few of housekeeping rules. I would like people to type your names, organization, and country in the chat box right now so we know where you have joined us from. And there's a French translation. Please click on the interpretation button and choose preferred language. We'd also like people to keep your microphones muted when not speaking to avoid background noise. Use the raise hand feature if you wish to speak during the question and answer. So as the presentations and the conversation is going on, you could type your questions in the chat. I would also like to notify you that this meeting is being recorded. So with not much further ado, with the stage set, I would like to invite Dr. Robinson Nwati, who is also an ACHA steering committee member and also the lead of the Scorecard Technical Working Group, to give us the opening remarks. Thank you. Robinson, the floor is yours.
Thank you very much, Rod. And good afternoon, everyone. And glad to be here with all of you, and glad to see so far 55 to 54 people have joined us. We're hoping we are going to be able to increase that number to around even 100, as you had seen in our registration box. And I hope I'm audible enough. Maud, you can confirm if I'm audible enough?
Yes, we can hear you.
Okay, thank you. Let me proceed. I would like also to just mute the camera a bit, so that we are able to reduce the bandwidth so that the connectivity does not drop off, if that is okay with the rest of the participants. Welcome again, everyone, for taking the time to join us on this wonderful afternoon. It's an afternoon in Kenya. And as Maud has introduced ACHA as a network of grassroots civil society organization that has had one major target, that is to see an Africa free of cervical cancer. And as per the WHO targets, that is by 2030. And we are already we are entering 2026. And hopefully this can be a vision that can be realized. And as we all know that in Africa, our women face a very significant health disparities, inequities, and challenges, and cervical cancer should not be among them. We know the challenges that we face as Africa, including political challenges, which impact our health and our health systems. And this is something that we should be able to overcome and ensure that our women, our future generations, are cervical cancer free. Because some continents have been able to achieve this, and Africa should be among those continents. So as ACHA, we do have 5 main work streams that work towards elimination of cervical cancer. One is the advocacy and research. We have capacity building and training, fundraising and resource mobilization, community engagement and outreach, communications, and IC materials. And all these work streams have been very active throughout the last 2 years where we've been working as ACHA, and we have ensured that we are working towards elimination of cervical cancer at the bottom right as our main vision. And as part of ACHA's scorecard, we came up with the idea that we formulate an ACHA Aspire Cervical Health Scorecard, which the CSOs can use to create advocacy and to fast track the policy actions of our governments, so that we ensure that the investments that have been put into health towards the elimination of cervical cancer are held accountable. And this has been a very comprehensive assessment tool, which all the countries that have been giving HPV vaccination have been doing cervical cancer screening and offering treatment programs, including trainings for civil society organizations, have been using, and we intend to use this scorecard so that at one glance or at one stop, you can be able to view how is Kenya doing, how is Eswatini doing, how is South Africa doing, how is Cameroon doing towards elimination of cervical cancer. Because just as we saw with polio, you cannot kick out a disease if it is still affecting your neighboring country. So you all have to work towards one collaborative goal to ensure that we are able to kick out or to eliminate cervical cancer. Because if it is eliminated in Kenya and yet we are still having infections in Tanzania, we cannot talk of elimination. So that is what ACHA has been working towards too. We have not done this alone. We have done this together with the group of consultants who have been helping us, who are experts in formulation of scorecards, who have been assisting us to ensure that we come up with an ideal tool that can be both easy to use and also can be updated continuously by the various countries that have been involved in this. We have about 12 countries where we are going to pilot this tool, and key among the countries where we want to start with include Kenya, Malawi, so that we have equal representation within the region for elimination of cervical cancer. And towards doing this, we have a very elaborate plan today that we are going to present to you. It's going to be shared in the chat. We are going to share with you the program. We're hoping to have your attention for about the next 2 hours so that we're able to discuss what the ACHA scorecard is all about and even hear from the consultant team themselves, even hear from African representations who are in the advocacy presentation pillar, tell us more about what we think that our ACHA Aspire scorecard can be able to achieve. And to give us more details towards this, I'd like to invite Benda Kizaka to be able to quickly take us through, to give just keynote addresses on who are going to be our speakers, what they are going to talk about, and even also tell us a bit about the role that Kirere Health, which has been the secretariat for ACHA, has been playing towards implementation of, formulation of, and realization of the dream of this ACHA Aspire scorecard that we are going to present today. And I thank you very much once again for making the time to join us. And those of us who can reach out to our colleagues and our fellow friends, encourage them to join so that they don't miss out on this great launch today. Thank you very much. Back to you, Maud.
Okay, I'm not sure. Thank you. Thank you so much, Dr. Robinson. I hope you can all hear me.
Yes, we can hear you.
Yes, we can hear you.
Okay, I'm trying to put on my camera. It says not able to, or now I'm able to. And also you can see me, I hope. Fantastic. So good afternoon, good morning, everyone, from wherever you're joining us. And thank you so much, Maud, and thank you, Dr. Robinson, for kickstarting this meeting today. I want to invite everyone to join us on a journey today, where we're going to be talking about the ACHA Aspire Cervical Health Scorecard. And I'm delighted to mention that on this call today, we have different participants stemming from civil society, government representatives, global actors in industry, as well as policy organizations such as WHO and Africa CDC, and also members of ACHA who have been working with us all through in putting together the tool that we're going to be unveiling today. I'm also excited that all of you have taken this afternoon to join us. And I will be taking you through a brief introduction of why we're doing this and what it means to eliminate cervical cancer for civil society. First, as a start, just to recognize that this work has been done with support and in collaboration, in partnership with various partners, amongst them Cancer Research UK, as well as FIND and Kilele Health. And we've also been having support from consultants as well as technical experts within the ACHA network. And with that collaborative, I also want to mention one of us who was an integral part to the formation of this scorecard, but who sadly passed on this year. That is Jane Kabaki. And why I want to honor Jane Kabaki is because as a breast cancer survivor, she had also dedicated her time towards ensuring that we can work as a network to form and formulate solutions that can bring elimination, because cervical cancer is the one cancer we can beat. And so with that moment, I would want to honor Jane Kabaki and all the other survivors that have left us, but have given us the fire to continue with the work we do. So why are we here today? ACHA is a membership organization. We are African Cervical Health Alliance, a grouping of civil society organizations that have come together and said, we have to act now. And there is no better time to act than on the month that we are commemorating the World Cervical Cancer Day of Action. This being the first day and the tagline being Act Now from WHO, we felt that as ACHA, it's important we also unveil the tool today. Now, in our agenda today, I would want to just present to you who we are and what we do and why we do it, as well as a brief introduction of the ACHA Aspire Scorecard. The bigger unveil will be done by our technical experts who will be able to showcase to you all the tools and the exciting things that they've come up with, and we will have a Q&A. Aspire for us is an aspiration. As we all know, progress towards elimination in Africa has been slow. We also know that some countries are really making strides, such as Rwanda, while other countries are still at the inception stage to introduce HPV vaccination or even think about screening with high-performance screening tests. And we also know not all African countries have invested in actual treatment. But we also recognize, even in the countries that some of these gaps are, we recognize that some countries have been working hard to bring community education or awareness, or to do other things that would lead the needle towards elimination. And that is why for us, this is a tool not to name or shame, but a tool for collaborative accountability. And that is why even for us today, we're being accountable to all of you as stakeholders and partners to say we've put this tool together and we are working together towards unveiling it. Now, as Maud mentioned, we are grassroots civil society organizations, some formed by survivors, some formed by caregivers, some formed by people of goodwill who want to make a difference in the communities that they serve. And our members are vast, and our members are with a wealth of experience, having worked in many fields for very long. For example, increasing awareness in communities or reducing stigma, demand generation, navigation for access to treatment, both for cervical cancer and other cancers and other diseases as well. And even offering services themselves where, for example, in hard-to-reach areas, our civil society organizations bring the experience of being the last stop towards elimination. And lastly, our organizations constantly engage governments and other state actors to ensure that we can advocate for the things that matter, as you've seen from the video from one of our members. Now, in ACHA, we are in 16 countries currently, but we're keen to get to all 54 countries of Africa and the 49 that are WHO members in Afro. We have 32 organizations right now from the 16 countries. We would be keen to ensure that we can reach more organizations so that every woman everywhere and every girl is reached. And lastly, we have over 155 advocates. And these are health advocates that have dedicated their time to be able to reach communities with knowledge, but also reach governments with collaborative efforts so that we can eliminate cervical cancer. The why we do the work we do is because we recognize civil society are actors and catalysts, bridging health systems and communities, bringing tailored messaging with the culture lens, ensuring that we bring our powerful testimonies and lived experiences, and with presence and versatility to reach the farthest corners, bringing advocacy to the forefront. And we believe firmly that it takes a village to raise a child. And therefore, even in ACHA, we are not dropping the ball. We are partnering, we are planning together, we are practicing cervical cancer elimination in the communities together, and we are amplifying the policy that has already been formulated by our governments, but also bringing feedback mechanisms into our government technical working groups. That's what our members do. We believe in multi-sectoral collaboration, evidence-based advocacy, and sustainability, as will be seen from the work that we do in capacity building, stakeholder engagement for our members, as well as technical support and advocacy. One such work that we do is the IEC materials in ACHA. The government of Kenya supported us with already validated IEC materials. And ACHA has proactively and accountably ensured that these are available to all our members as open source online. And these are validated and culturally appropriate, and right now have also been translated to French and already are being unveiled in Cote d'Ivoire. Secondly, these materials are used both in corporates as well as in communities to educate women and girls, communities and actors that cervical cancer is eliminatable, and we can do it. We can set the targets going within our lifetime. Secondly, ACHA, supported by the various partners, including Project ECHO, Expertise France through Success Project and Unitaid, and working with Kilele Health as the Secretariat, launched in August an 8-month virtual training capacity building initiative that is the ACHA Advocacy ECHO. Just this Wednesday, we will be having our 4th session where we'll be talking more about community engagement and how we can advocate for resourcing in community engagement. Lastly, in policy advocacy, we engage with governments, as I've mentioned, like, for example, in February of 2024 is when the government of Kenya, represented by the Director General of Health, approved the use of ACHA, the IEC materials that now we call ACHA IEC materials. And lastly, we're constantly engaging key opinion leaders so that we ensure that there is representation in understanding the science of elimination, but also understanding how well to communicate. What you're seeing there is one of the convenings that we've done with AHETI, one of our partners, in getting faith leaders to Nairobi to understand the science and the faith connection in safeguarding women's health. Lastly, this is the team that leads ACHA. And I want to honor each one of them because as a team, we are reaching across our membership to ensure that the message is clear, to ensure that the engagement is robust, and to ensure that we can bring the knowledge that civil society organizations bring on the table. There are opportunities to partner with us. As you can see, we keep very good company. And I want to honor the partners that have already come on the table, starting with Ministry of Health in Kenya, as well as Ministry of Health in Cote d'Ivoire, Cancer Research UK, FIND, Expertise France, Unitaid ECHO, the Rose Foundation that gave us the HPV validated materials for HPV testing and screening and self-sampling for us to be able to customize and make them realistic for African utilization. And lastly, to recognize that for each one of you who are on the call today, we have opportunities to partner in capacity building of our members and other civil society organizations across Africa. In terms of service delivery, through restricted as well as non-restricted grants, our members are managing service delivery in the community. We also present a speakers bureau where if you require meaningful engagement with civil society, we'll give you inroads to the various members so that you're able to drive also your messaging as partners in elimination. And lastly, our members are constantly looking for technical support in various areas of expertise. as well as any commodities that you may have that can support grassroots action. I want to say that as participants, especially looking at the participant list and seeing that we have quite a number of civil society participants, it's not foreign to know that we have enablers and barriers to community action in elimination. But the civil society organizations have worked very creatively to bring partnerships with governments, supporting by sitting on technical working groups, as well as ensuring that we can bring the messaging that is grounded in local values and catalyze action from our deep existing networks so that we can ensure that there is community education and engagement. Some of the barriers that we face, as you can see on the screen, limited resources for grassroots civil society organizations, minimal inclusion in planning for strategies, and that is why we are training our members in advocacy so that they can sit on various technical working groups to bring the voice of the community on the table. Often, communities have mistrust and misinformation about health systems, and we want to be able to work in communities to demystify these myths, misconceptions, and to bring factual information that can help people make decisions. And lastly, one of the challenges that we are addressing right now is the limited lack of data sharing that can show visibility on what countries are doing and what our members are facing in the communities as we bring elimination to the table. And that is why it gives me joy to say that today we will be unveiling the ACHA Aspire Scorecard, which is a tool for us for ensuring that the progress that is currently slow can also be earmarked with metrics and indicators that would show what else is happening in the country. And so, if you would like to get in touch with us, as I mentioned, we have the IEC materials openly available on the website, which is listed there. We're constantly posting the things that we're doing, and we also do have our emails there that you can be able to reach us through so that we can continue engaging. But right now, it gives me great pleasure to just invite some of our speakers, starting with Africa CDC, Betty. Betty, I hope you're on the call. Betty Kabarega, who is the public health practitioner and representing the Africa CDC. She's a certified nutritionist with over 10 years of experience in public health, human nutrition, and health system strengthening, and with broad expertise spanning from nutrition, NCD programming, public health system strengthening, as well as cervical cancer, accelerating cervical cancer elimination. She supported the Africa CDC implementation roadmap for the accelerating of the elimination of cervical cancer in Africa by 2030. Betty, you have the floor. Thank you.
Thank you so much, Bena. Can I confirm that you can hear me?
Yes, we can hear you.
Yes, we can hear you.
Okay, I was trying to put on my camera. Thank you so much, Benda and colleagues, for really inviting us to be part of this incredible milestone. Distinguished leaders of the African Cervical Health Alliance, representatives of civil society organizations, esteemed partners, ladies and gentlemen, good afternoon. I'll say good afternoon, but I believe it depends on where you are. If where you are, it's a good morning, good morning. It is really an honor from the Africa CDC side that we have joined you today for the unveiling of the ACHA Aspire Cervical Health Scorecard. I would like to start by commending ACHA's leadership in uniting civil society across Africa towards a shared vision of a continent which is free of cervical cancer. Allow me to say that really today's launch represents a major step in placing community voice, accountability, as well as transparency at the center of cervical cancer elimination. I think we already heard from the previous speaker that cervical cancer remains one of the most preventable yet deadly disease affecting African women on the continent. The tools exist around vaccination, around screening, and also around treatment, but yet we still have gaps around access as well as inequities. So it is our responsibility as the continent to make sure that we overcome these challenges and make sure that we can save the lives of our people. This is why as Africa CDC, the Aspire Scorecard is so important, as it provides a clear, actionable evidence to guide advocacy as well as accelerate progress towards cervical cancer elimination. I'd like to touch base a bit on the work that Africa CDC has been doing in the area of NCDs, but specifically on the area of cervical cancer. In 2022, Africa CDC launched its first ever continental strategy on NCD injuries and mental health. And guided by this strategy, last year we validated with our member states the continental implementation roadmap for accelerating cervical cancer elimination by 2030. So Africa CDC is really committed to supporting member states to achieve the WHO 90-70-90 targets. And through our approach and our programs, we focus on three important pillars when it comes to cervical cancer elimination. The first of our pillar is around supporting member states around the HPV vaccination, which we focus our efforts around scaling vaccination through community engagement and culturally sensitive communication. We also focus on expanding delivery platforms, including private providers as well as primary health care centers. And also we focus around integrating HPV vaccination into adolescent health, as well as other integrated models like the HIV and primary health care services. The second pillar that we focus on is around screening and treatment of precancerous lesions for cervical cancer. And under this pillar, we focus on community mobilization and stigma reduction, as well as demand for creation. We cannot really talk about cervical cancer and chronic diseases and leave behind mental health. There's a saying that says that there is no health without mental health. So at Africa CDC, we recognize that as part of cervical cancer effects, we also include mental health as part of our approach. And we also look at how to leverage task shifting and integration of screening into routine primary health care, as well as reproductive health services. As part of increasing our efforts towards screening and treatment, we also work around with member states to come up with innovations through things such as mobile clinics, digital tools, as well as other area and available screening tools. The third area that we focus on is around access to diagnosis, treatment, and care, where we really look at strengthening the diagnostic capacity and decentralizing services. Here, I can maybe mention around two important aspects that we look at as a continental entity. The first one being supporting member states for food procurement of different, medicines, as well as diagnostics for cervical cancer and other NCDs generally. But we also look at the building workforce skills and improving referral pathways to make sure that access to the diagnosis and treatment is also taken care of. We also support member states in the area of expanding palliative as well as psychosocial care with community involvement. So these three pillars are the ones that our work on cervical cancer focuses on, obviously guided by our implementation roadmap for accelerating cervical cancer elimination by 2030. So this roadmap really also talks about establishing some of the centers of excellences around the continent, because we believe that African problems can be solved also by African, solutions. We believe that we have solutions that we can be able to share across the continent, and these centers of excellence are supposed to be centers of learning and cross-learning and cross-country support in the area of cervical cancer. So when you look at this pillar, I think from the previous presenter, when you look at these Africa CDC pillars, you find that they really closely align with the Aspire scorecard. This highlights a strong synergy between community-led monitoring and continental efforts. Africa CDC recognizes that data system and community accountability are central to elimination, and some of the ongoing work that we have been doing to ensure that we strengthen data systems in member states include that the development of a continental NCD injuries and mental health surveillance indicators, which we believe that is going to be supporting in terms of harmonizing reporting on the continent, as well as monitoring, progress towards member states' efforts in NCDs. And I would really like to highlight that as we have developed a set of 25 continental key indicators, and among these 25, we have 3 that focuses on cervical cancer. Secondly, we launched our guidance on strengthening NCDs and mental health surveillance systems, which also has a pillar that talks about engagement with civil society organization as well as private sector to ensure that data is appropriately collected, used, and also to make sure that these key contributors are part of the validation process. We are also, working at the continent level to ensure that we support sectoral engagement and coordination, as well as action of key stakeholders on the continent when it comes to NCDs generally, but specifically for this focus, specifically for cervical cancer. One of the programs that we have that is in the pipeline that we are still working around is we are working on developing the NCD's injuries and mental health continental dashboard, which is where I really believe that the Aspire scorecard can serve as a complementary community-generated evidence tool. Colleagues, I would like to highlight that today's launch really demonstrates how community-led data can energize national accountability and drive smarter investment and policy action. This scorecard is really a landmark contribution because, first of all, it brings transparency through simple actionable ratings, and it also covers a full continuum of care from vaccination, screening, treatment, policy, as well as governance. It also strengthens evidence-based advocacy, which enables CSOs to engage governments credibly as well as constructively. Under this part, I would like to highlight that also this, from the Africa CDC side, we see this scorecard as a tool that is going to provide with us strong evidence for high-level advocacy, including at the highest level of the continent, which is at the heads of state level, which is really an activity that Africa CDC will be glad to leverage on and also support. So Africa CDC strongly supports this model. I would like to highlight that there is really no elimination agenda that can succeed without community trust, community engagement, as well as community oversight. Allow me to conclude by saying that as we unveil the Aspire scorecard, I'll call on all of us, governments, civil societies, partners, as well as communities to act with urgency to ensure that every girl receives the HPV vaccine, ensure every woman has access to screening, and also ensure that all women receive timely quality treatment if diagnosed with cervical cancer. And lastly, hold each other accountable through tools like the Aspire scorecard for accountability as well as improved outcome. I'd like to say that Africa CDC stands ready to work alongside ACHA and all other partners to build a future where no woman in Africa dies from a preventable cancer. I thank you very much, and I really wish you a fruitful deliberation. Thank you so much, and over.
Thank you so much, Betty. And really, your words echo, because this is a tool for us to go to the highest level of advocacy, not just for awareness education, but also for investments in elimination. And that is why we're very keen to work with yourselves as Africa CDC and other bodies across Africa to see that the tool is well cascaded in the various corridors of decision making so that we can serve our women well. We appreciate Africa CDC. Now, it gives me great delight to everyone who is present today to invite Dr. Dile Isimoha, who is a surgical oncologist, cancer control specialist, public health leader, and the technical officer in cancer control for WHO Regional Office for Africa. Dr. Dile is a surgical oncologist with over 15 years of clinical public health experience in digestive, gynecologic, and breast cancers. She holds advanced training in colposcopy, cervicovaginal pathology, epidemiology, and palliative care. From 2010 to 2021, she served as a surgical oncologist at the National Hospital in Niamey, Niger, main tertiary facility. Sorry, she's Nigerian, not Nigerian. And Dr. Dile has, since 2021, been the regional advisor for cervical cancer control at WHO Regional Office for Africa in Congo, Brazzaville. I'm happy to say that Dr. Dile is very supportive of ACHA and also very supportive of the various governments that we're working with. And we've seen her technical expertise in supporting and advancing the WHO global initiatives, including cervical cancer elimination strategy, global initiative for childhood cancers, and the global breast cancer initiative towards equitable integrated cancer care across Africa. Dr. Dile, you have the floor, and welcome. Thank you.
Thank you so much, Brenda. Thank you. Thank you so much. I will share my screen. Good afternoon, colleagues, and
good afternoon. As Dr. Dile is sharing her screen, I will also ask if you have any questions to any of the partners that have already spoken, or if you have any anticipatory questions about the ACHA Aspire, you may post them on the chat and we'll be able to get back to them. Thank you. Over to you, Dr. Dile.
presentation mode. Okay. You see my screen?
Yes, it's
Can
visible.
you see my screen? Okay. Are you see?
Yes.
Can you see the screen, the big one?
Now we see your presenter view.
Not the big one.
Mm-hmm.
You're not seeing the big screen. Eh?
Mm-hmm.
Okay. Okay. Sorry. Okay, I think I will not take a lot of time. Let me just start.
Or maybe Dr. Dile, yes, it's showing now.
Yes. Okay. Is it okay?
Yes.
Okay. Is the same screen that you are seeing?
Mm-hmm.
Okay, so no problem. Just let me just start because okay, thank you. I will just share it like this. Huh?
Just share it like that.
Yes.
Okay, thank you. Good morning, good afternoon, colleagues, and congratulations again to ACHA. Congratulations for this great achievement. And congratulations for this great achievement, and also we are very proud and very happy that you invite us in this. Okay. Sorry, I'm coming just a minute. Okay, I think perhaps I can share it with you, Benda.
Yes, I can help to
Yes, sorry, I
show
have
the
just
screen.
technical issues, sorry. Because it also doesn't move on my side. Sorry. Let me share it with you.
Okay.
I apologize for taking your time.
Not to worry. And as we are just showcasing, maybe I can just read out some of the comments that have come already on the chat. For every person, you can be able to access the Africa CDC roadmap via the link that has been shared. Secondly, there is a question from Dr. Julie Road. How can ACHA make sure that the messages of the scorecard reach the decision makers? Thirdly, we have a question from Himo Shuja. Himo says, how can a scorecard effectively measure long-term nonlinear outcomes such as the institutionalization of reforms, a sustained shift in the public narrative, or the building of a resilient, self-sustaining coalition whose full impact may only be realized years after the advocacy campaign concludes? And I think those are some of the things that we will be hearing from our technical experts consulting team. So Himo, that is a question that will be responded to. Thank you. I am also checking that the presentation has come through so that I can share it. But just to remind everyone, please post your questions on the chat or your comments about the conversations that are ongoing, and we will be reviewing that as we go along. In the meantime, Dr. Dile, maybe if you can be speaking into the WHO 90/70/90, even as I'm awaiting your slides to come through. Dr. Dile?
Yes, thank you. Thank you, yes, but I will start. I think I will start. Thank you. Yeah, right. Thank you so much, and let me start. Thank you so much, colleagues, and congratulations, ACHA, for this. So it's an honor to join you today for this unveiling of Aspire Scorecard. Shortly after we marked the first official World Cervical Cancer Elimination Day on the 17th November. I want to sincerely congratulate ACHA for its leadership, its mobilization capacity, and its and its continued commitment to making cervical cancer elimination not only a technical agenda, but a real social movement across Africa. On behalf of WHO Afro, I reaffirm our strong and unwavering commitment to support countries on the path toward achieving the 1917-19 elimination targets. Did you receive it?
Yes, I've received it. I'm going to show now. Yes.
Yes.
I've received it. I'm going to show it now. But, oh, wow. I've lost all your formatting.
Okay. Umi, can you share? I have my colleague Umi, if she can share also. Umi, can you share on your
Yes, we
side?
can give her the right to share, yes.
Yes, if you can give her the right, she will share. Just to tell you that really, eliminating cervical cancer requires coordinated action across multiple sectors and disciplines. You need HPV vaccination because this vaccination relies on strong collaboration between immunization programs, school, communities, and communication teams. The HPV screening must be fully integrated into primary healthcare, HIV services, and sexual and reproductive health platforms. Diagnosis and treatment, the third pillar, depend on strong system for pathology, surgery, oncology, and palliative care. Data, as you know, are the backbone of decision-making, accountability, and targeted intervention. No single team can do it alone, can eliminate cancer, cervical cancer alone. We need a multidisciplinary and cross-sector collaboration. Okay.
I lost the formatting too, but I can share my screen.
Okay. Okay. So I think just me do it. Okay. So it's okay. Umi, let me just. It's okay. You can let just me finalize. And not a single team can do it alone, as I said. We need multidisciplinary approach. You can just let the presentation. I will just do it like this. Thank you. Umi, it's okay. Why an accountability scorecard is needed? This scorecard that we develop, ACHA, is something that responds to a real need, as we all know that measurement is the foundation of improvement. A simple, visual, and comparable tool that shows where countries stand on vaccination, screening, treatment, and governance. A tool that is easy for minister, parliamentarian, and partner to interpret. A tool that complements WHO monitoring system, including the WHO cervical cancer elimination dashboard, the global HPV vaccination database that we already have, the DHS2 screening modules that we support countries to develop, our women integrated services for women for cancer that we are implementing in 3 countries, and the pan cancer components that we also have as WHO. This tool that we develop provide a platform where progress is celebrated. The bottlenecks are visible early, and partners can rally around national priorities. This tool can truly accelerate progress if it's used collaboratively. Allow me to outline how WHO approved currently support countries to accelerate progress toward elimination. We support the countries to develop national guideline and policy like NCCP, cervical cancer elimination strategies. We support countries to integrate HPV vaccination in the national cancer immunization program. We support countries to make available the screening and treatment into national primary health care packages. For the vaccination, we support countries to adopt the single-dose vaccination to improve access, because this can help to improve access and operational feasibility. We support countries with strengthening micro-planning and communication, especially for out-of-school girls, which is a big component in our region, as you know. The HPV, in terms of screening and pre-cancer treatment, we support the introduction of high-performance HPV testing, the training of primary healthcare providers in sample collection, triage, and thermal ablation. We support promoting integration into HIV and SRH reproductive health platforms. For invasive cancer, together with some partners, we support to improve pathology, radiotherapy, chemotherapy, and palliative care. We support to link countries, initiative, and partner, conventional and non-conventional partner. For data and monitoring and evaluation, we support integration of HPV screening and treatment into the DHS tool. And we support to develop dashboards that support decision-making and investment priorities. The value of this ASPIR scorecard is so high. The 27 well-defined indicators covering HPV vaccination, screening, treatment, policy, and governance are well-defined, and they are a light scoring system. This light scoring system that you identify, green, yellow, and red, allows instant interpretation of progress. A platform that's strengthening civil society engagement, community accountability, and policy dialogue. This tool supports countries to identify where action is urgently needed, which investment will have the highest impact, and how partners can align their efforts to avoid duplication. It's not a parallel system. It's a complementary tool that reinforces the accountability ecosystem. How WHO AFO can collaborate? We can support to align with WHO standards. We will work closely with ACHA to ensure that indicators, thresholds, and definition are aligned with WHO recommendation and global monitoring framework. Secondly, we can support for piloting. For the 3 pilot countries, starting in January 2026, WHO AFRO can support technically the interpretation of indicators, guide the integration with national system, and ensure alignment with existing dashboards. Tertiary, we can support leveraging the result for action and resource mobilization, because this scorecard will help to identify where partners can invest most effectively, can support to strengthen advocacy for cervical cancer programs at national level, and support WHO AFRO initiatives such as WICS and the cervical cancer elimination implementation. What I want to end with, dear colleagues, the period of 2026 to 2030 is a decisive window. What we do now will determine whether Africa becomes the first region to make substantial progress toward elimination of cervical cancer as public health problem. The Aspire Scorecard is timely, strategic, and powerful platform for mobilizing action. WHO AFCO stand ready to work hand in hand with ACHA, government, civil society, and partner to sustain the momentum and accelerate this elimination. Together, we commit transparency and unity. We can move Africa closer to a future free from cervical cancer. We can do it together. Thank you for your attention.
Thank you so very much, Dr. Dile. And that closing in itself, we can do it together, is a very strong support to ACHA, and your commitment that you will support in strengthening the national advocacy work, as well as the technical support in ensuring that the governments work with ACHA to strengthen robust monitoring systems, is really welcome. Because for us, as I mentioned when we started, this is a collaborative accountability mechanism. And we are happy that you, as WHO, who is the gold standard for measurement, can then be able to take some of the work that we're doing and work with us to ensure civil society work matters, even as we run towards elimination of cervical cancer. Now, without further ado, I think I would like to just hand over to Maud, who will be inviting our technical team to take us through the tool that Dr. Dile has highlighted very well, and we can be able to also experience what the tool is about. Maud?
Thank you, Brenda. And thank you very much for the support which we have already garnered through CDC and WHO. So right now I'd like to call the consultants, and I think it will be Nicholas who will do the presentation and demonstration of the ACHA Aspire Cervical Health Scorecard report. So if Nicholas, the stage is yours. Thank you.
Good morning, good afternoon, team. Kindly confirm that you can hear me and you can see my screen.
Yes.
Yes, we can hear you and you can see the screen.
Thank you very much. So my name is Nicholas Mwenda, one of the team members from Artemis Health Networks. We've walked this journey with the ACHA Aspire Secretariat and coordinated the participation of all ACHA members and other stakeholders that who have advised the process to come up with a draft ACHA Aspire Cervical Health Scorecard. And it's my pleasure right now to take you through that journey and eventually to have a feel of what we were able to come up with. And my pleasure again to hope that I'm gonna get, or the team is going to get, some good feedback on how we can take this forward, and appreciate how useful a scorecard could be to nudge the African countries to invest more towards elimination of cervical cancer in the continent. So this presentation will be around how we develop the scorecard. That is the development process. We will mention a few words around how the literature review was done, the kind of indicators that we hope that they will find their way into the final scorecards. We'll mention a few words around how we engage stakeholders, and then eventually present the draft scorecard. And then we'll have a short discussion on what we think should be the next steps towards having a scorecard that really supports stakeholders in the cervical health space in the continent to eliminate cervical cancer. So I know the speakers who came before me have spoken about the burden of cervical cancer in the continent. And we've also spoken around the WHO strategy of 1970-90 and importance of the same, especially in Africa, and the importance of embracing pragmatic solutions for the African continent towards fighting cervical cancer. I loved the CDC's presentation around having local kind of solutions to the cervical cancer strategies and programs in the continent. And this is very important, especially for Africa, where we know things to do with culture, for example, which is really stemmed into the continent, is really significant for us. So I'm happy that as a team, we are able to recognize that Africa is a little bit unique and it needs to have African solutions to some of the challenges that we have as a continent. So as a team of consultants and engaging other stakeholders, our key objective towards this was to formulate a scorecard that civil society organizations in the so many countries can use to encourage governments and have other supporters or other stakeholders invest in strategies that eventually will lead to elimination of cervical cancer in the continent. So the purpose of the scorecard would be a snapshot of a situation analysis or assessment where countries can have a look at how they've performed in various indicators. And due to that visibility, it would enhance and leverage domestic civil society organizations and their role in advocacy for better outcomes. So basically having these indicators in a manner that the indicators are agreeable across all stakeholders, and to put CSOs at a stage where they can advocate for the various players to contribute better, whether it is in finance or in technical strategies to fight cervical cancer. And then, of course, this is a tool that can be continuously be used, where it compares technical indicators like access to screening or access to treatment options against what countries have invested in cervical cancer elimination strategies. So in terms of the entire process, we started with a literature review, looking at what the best practices are around scorecards, but also the best practices around what countries are doing. You realize that African countries are in very diverse stages in terms of elimination. We have countries that are almost there or far ahead than others in terms of even inclusion of cervical cancer vaccination in their national immunization strategies. And we have other countries that do not have that. We have countries that screening is part of the public health interventions. Others have not even started that. And we did compare those countries across Africa to have a look at what really is the best practice across the continuum of care for cervical cancer. And then we looked at the indicators that are acceptable across the continent and also globally around primary prevention, that is vaccination, the secondary prevention, tertiary prevention, and other cross-cutting indicators. And then we explored areas where some of these indicators could be coming from. So some of the indicators around cervical cancer are globally accepted and routinely measured at the national level. So we looked at the district health information systems and national surveys for various countries. But there are other indicators that need to be looked deeper into, including indicators that are financial in nature. For example, the proportion of Ministry of Health budgets, for example, dedicated to cervical cancer prevention measures, that is not routinely measured. And it's really varied, especially around how countries present their budget information and the like. And we also looked even deeper in cancer registries. This being a civil society organization kind of intervention and being African, we hope that as we go ahead or forward with this scorecard, we'll be able to even identify indicators that are beyond primary prevention or even before primary prevention, and even indicators that are after tertiary prevention. We've had a mention in this call today of indicators or interventions around governance for cervical cancer investments. I've just mentioned around the cultural practices. Ben has mentioned indicators around the participation of civil society organizations in advocating for better interventions for cervical cancer. A presenter here spoke about longitudinal kind of information. For example, a measurement on whether commitments by countries or commitments by regional bodies are met along the way. So some of those indicators are really welcome, and I think it's one of the purpose why we are having this discussion. And then once we put all these literature review, the preliminary indicator selection and us pointing at where we are getting the indicators of the sources of those indicators, we designed the scorecard using a common tool that is Power BI that's good in visualizations. And then that zero draft of scorecard was presented to stakeholders, and especially the secretariat at ACHA and even member countries for the civil society organizations. And that feedback was incorporated to get a finalized draft. And at this stage now, we're looking at the next steps. I mean that this is one of the reasons why we are in this meeting around farming up of indicators, getting more ideas on the same. Ben has mentioned exploring partnerships to take this forward, including reaching out to more CSOs, more countries, onboarding national ministries of health, other institutions like the Africa CDC, WHO, and the like to also contribute their insights to this, and eventually having an adaptable and readily accepted scorecard that can actually precipitate action that leads towards elimination of cervical cancer in the continent. So around literature review, of course, we had the usual engagement with the ACHA Secretariat, and we did the usual document search, focusing on 12 countries as listed. And then we synthesized this to get a feel of the status of cervical cancer implementation of interventions in Africa, but also around how to use scorecards and whether they've been used not only around cervical cancer, but also in other health interventions. So in summary, we have seen that we are lagging behind as a continent around vaccination coverage, screening, and also treatment coverage. We also analyzed the various ways in which different countries have approached their cervical cancer interventions at the level of policy and frameworks. And then very important for Africa, we've seen the intersection between the scientific management of cervical cancer and the programs and the sociocultural beliefs we have in Africa around cervical cancer and how that should count when instituting programming for the same disease. So we are in a transition in terms of funding, especially from the US government. And so we had that aspect and we explored how that impacts our interventions in the country, in the countries of interest, which we, by extension, in Africa. And we've looked at what has been done around scorecards and how they've been used to foster accountability and related best practices for the scorecards. So in terms of indicators, we basically went for indicators that are routinely monitored. I know we have many sources from WHO to Africa CDC, World Bank around both medical, stroke technical, stroke programmatic cervical cancer indicators. But we also have indicators around budgetary provisions that should go in line with the fight against cervical cancer. So we looked at those routine indicators that are available in the existing data sources for each country, and especially for indicators that we could get at the WHO Afro. The reason for this is that we need, when we start comparing performance, quote unquote, across countries, we are able to stand by the sources of indicators, and the indicators will be readily available and acceptable to people and countries and ministries that we'll be dealing with. So as you can see, we had indicators around primary prevention, as you can see around vaccination coverage and whether HPV vaccine is present in the immunization strategies for the countries. we had indicators around the secondary prevention, that is the screening and availability of what it needs to be for screening to take place, including HPV tests availability and the like. We had tertiary prevention kind of indicators around treatment of people or women who are eligible for treatment, availability of tertiary treatment options in these countries as well. And then, as you can see, we also measured whether that data is readily available. And as you can see, for many African countries, as you move from primary prevention to secondary and all the way to tertiary, we are getting lesser and less availability of data. And I think this is one of the areas that we also need to measure so that countries can pull up their socks in terms of availability of these data sets. We also looked at other cross-cutting kind of governance stroke health system-wide development indicators, like availability of national cancer control plans, or whether cervical cancer is really underscored in the national cancer control plans if they have some. And it is at this point that we really hope that we could get more pragmatic indicators that are applicable to Africa and that are readily measurable, and that will assist in strengthening the cause for the main indicators that we've mentioned earlier. And some of these indicators of that we called cross-cutting includes whether countries have population-based cancer registries or screening registries, or whether countries have training package on cervical cancer, and the like. And some of these indicators are not readily available, but they are here for consideration because we think that and even in many technical documents across CDC, WHO, these are some of the enabling factors for countries to fight cervical cancer, and we really think that they need to be measured so that their presence can be encouraged. And of course, with the presence or with improvement in these indicators, we are going to get an improvement in the other main indicators. So we also are looking at other indicators that are linked to lived experiences. For example, the presence of survivors or caregivers in national technical working groups on cervical cancer or on cervical cancer. So we've learned from many disease areas, including for chronic disease, that people who have lived the experiences, their presence in committees, their presence in, for example, benefits package forums or technical working groups is good for the course in which the countries would like to advance in various disease areas, and cervical cancer shows the engagement of the same. We believe that especially in Africa, where democracy has really gained roots, we've seen more public participation in decision-making for public good, for example, for budgets, for strategies. And we really think that grassroots organizations or citizens presented by grassroots organizations need to take center stage, because as they say in Africa, it is the wearer of the shoes that knows where it depends most, and we need to measure whether citizens are included, and so on and so forth. Lived experiences around mental health, and whether we are actually using survivors of cervical cancer as trained community educators and advocates. And these are some of the areas that we really hope through engaging people like the ones that are on this group, we are able to get even more insights so that we could be advised on what really matters and what is important for Africa. I will not go through all these indicators. I hope that you are able to get a grasp of some of the civil society action and engagement indicators that we had in mind. So in terms of stakeholder engagement, we developed a scorecard, of course, I had mentioned, and engaged the secretariat. And then we were able to speak to CSOs and actually had a tool that collected views on what they think should be improved on the scorecard that we developed. And we instituted all those changes and suggestions to the scorecard. And then we used Power BI to sort of have a visual kind of scorecard that is interactive with visuals, with clear data interpretation. And we hope that at the end of it, we'll have real-time updates from multiple data sources. Basically, having a visual presentation on how countries are performing across the 3 areas of cervical cancer elimination continuum, but also having the countries collect their own data sets and having a mechanism where they can upload that data sets, and then we could have some form of live update to the dashboard. And then instantaneously, everyone in the continent is able to see how they compare with the rest of the countries. The aim is not competition. The aim is to promote peer learning, so that if Cameroon is doing better in screening, and Kenya can learn from Cameroon, and if Uganda is doing good at tertiary prevention, then secondary prevention, even other countries can learn from them. And then we would like to have eventually a customizable kind of dashboard that aligns with the global and national targets. We know, as I had mentioned, many countries that are various kind of stages towards elimination of cervical cancer. Some have national specific or country specific kind of indicators. We need a scorecard that can take care of that as well. And then, of course, we need something that is easy to use, easy to understand. And in this, we adopted some level of coloring, green, yellow, red kind of coloring. And I think these are standard indicators, standard colors that are used in scorecards. And anyone or a lot of people can easily tell that red is not doing good, green is good, and yellow is improving, but room for improvement. If you are able to, you can scan the QR code on this screen. It should lead you to where the scorecard is. I've already, and I've add this link. So I will go ahead and take 2 minutes to go through the interactive scorecard. So basically, this is what we have as a landing page. So we have a very simple to use interactive kind of colored maps where you can select a country. You can select a country, and then you can select the thematic area, whether it is primary prevention or secondary prevention or tertiary. And then you can select the respective kind of indicators. And then the map should show you the country, the thematic areas that we've chosen, whether it's cross-cutting indicators, primary prevention indicators, secondary prevention indicators, or tertiary. And then for each of them, for example, if you select a country like, let's say, randomly Lesotho, you can pick what group of indicators you're interested in. Let's say it's primary prevention. And then from that, all the indicators around primary prevention should pop up. So the indicators around primary prevention are whether the country is being supported by Gavi, whether HPV vaccine is in national immunization programs, the incidence of cervical cancer per 100,000 population, which is a standard indicator for incidence, etc. For example, what vaccine type is available and the percentage of girls 9 to 14 who have received vaccination for the same. And if you pick, for example, the incidence, you're able to see Lesotho as a country here and how they perform. And you can also compare across countries. You can pick Ethiopia and Cameroon and pick other countries. And then using a color code of red, green, yellow, you are able to see how these countries are performing. The score is based on a threshold. Right now, we know we've not really, this is not a scorecard per se in terms of its practical use. Like you can't say now these countries are green and these are red. We have used thresholds at our level to assign who is yellow, who is green, who is red. So for you to use this tool as an accountability measure or accountability tool, the process is that you need to involve people who are responsible for decision making. Scorecards are sort of accountability measures. So you really want to use a yardstick that is acceptable to people you are holding accounts. You don't want to be presenting red to a group of presidents, and then they do not know how that red has been arrived at. So basically, this is for demonstration purposes. So if you can use this code here, you can interact at your own time with the scorecard. And also, I think Benda can be able to drop the actual link to this scorecard for people to interact with it along the way. And I think that will elicit some questions. And of course, this is the landing page for the scorecards. I had mentioned that. So, and then you should be having, let me see. Once you have, when you open the scorecard using the link, this is where you land, and then you are able to learn about ACHA by clicking that tab, and then the ACHA Aspire itself, and then you can view the scorecard, and all the indicators are defined when you click that tab. So kindly, you can interact with the scorecard as we go. And I will have a few more slides to go. So in terms of what kind of next steps we're looking at, we are looking at one, what we are currently doing, looking at stakeholder engagement, speaking to people with common interests, common objective of advancing cervical cancer objectives, elimination of cervical cancer in Africa. I'm speaking around Africa CDC, the World Bank, UNITAID, WHO, Africa Office, ETC, GF as well, looking at how better to take this forward, use this. I'm sure many of us here and even these global and regional bodies have a lot of experience using the scorecards, and they have a lot of inputs to that can benefit this scorecard. And then eventually when we have a non-scorecard that we've developed that is acceptable, that people can use to advance cervical cancer, to do cervical cancer advocacy, then we are going to train advocates, and these are civil society organizations, so that they can use this scorecard with their ministries of health in the respective countries, so that they are able to use it as a tool for better accountability, for commitments, because many countries have committed for so long against many areas to eliminate cervical cancer within their countries. So, and of course, we hope that eventually this scorecard can be continuously used to solve cervical cancer in the continent. And in conclusion, I know that we have experience. I've seen a lot of people who have served in healthcare in this space, in this call, that we know that evidence-based scorecard development enhances accountability. If you put the Ministry of Finance, the Ministry of Health, economic planning, global bodies, the political leaders in one room, and show them a scorecard that demonstrates yellow, green, and red, when they have really been involved in the definition of those thresholds, in the definition of what is green, what is red, what is yellow, and they are made to understand how to move from red to yellow and eventually to green, then that is a very powerful tool. We've used this as a continent in malaria. We've used it in Ramka with very nice demonstrable results. And then, of course, there's an aspect of, yes, using the scorecard, measuring globally recognized indicators, but also recognizing things that are realistic to Africa. A good example is the cultural sensitivities around Africa, peculiarities within countries. We know Africa is really diverse, and even peculiarities intra-country. We know countries are very diverse inside, and we have regions that are really different from others. And this being cervical cancer, women health, I mean, we need to make sure that we have the indicators that are alive to the context in the country, in the continent. And then, of course, we need to use data that we can stand by. So data that is acceptable by the ministries of health, data that is people have confidence in, and that is not refuted. So really stressing that this kind of data set has to be sort of developed and compiled in country before it can be used for a scorecard. And then, of course, this cannot be done unless people like you who are on this page, on this meeting, can come together, adopt, contribute to, and eventually accept to use this as an advocacy tool. I believe this is my final slide. I think I'm the one who has taken lots of minutes. I hope to stop at this point and invite any discussion as a result to this, and hand back the microphone to Benda and team. Thank you very much for your time. Asanteni.
Thank you very much, Nick, for that elaborate presentation. Yes, you took a bit of time, but it was necessary for you to do that so that you should understand the whole process. So right now, I'll call in Benda again so that she goes ahead with the Q&A and proceed on to the call to action. Benda, the floor is yours. Thank you.
Thank you so much. And I just want to honor the consultant team for the amazing work that they have helped us deliver, and also to the technical working group from the ACHA team that has been working on this tirelessly. I want to recognize the two key leaders, Dr. Robinson and Dr. Temptation Chigova, as well as Dr. Mwenda Valerian, who was leading the consultant team together with Dr. Nick, and to recognize our partners who are also represented on this call. We have Cancer Research UK that supported the HPV vaccination component, FIND that supported the screening component, and Kilele Health that has been supporting some of the coordination and some of the integration of the two pillars, as well as the treatment pillar in the the initial formation stage. Now, to start us off, I'd like to just confirm Betty is still on the call. Yes. To start us off, we have a number of comments and also a number of questions. And I'm just going to invite the three speakers so that they are all present as we are having the conversation on now questions that have been asked about the ACHA Aspire scorecard. To start us off, I want to say Aspire is an acronym. I had posted it on the chat. It is an acronym that stands for Advocacy to Support Policy Implementation Relevant to Elimination. That's Aspire. Now, to start us off, I would like to ask Betty. Betty, you mentioned in your presentation that the ACHA Aspire scorecard is yet another tool against other complementary tools that you have as Africa CDC. Some of the participants are keen to know what are the other tools that you have. You have just about a minute to respond to that question. Thank you.
Yeah, thank you so much, Brenda. So from the Africa CDC side, really, let me first start by congratulating ACHA and the team for this. Is really impressive from the presentation that just happened. It's really impressive. And from the Africa CDC side, so like I mentioned in my remarks, we are looking at developing the continental scorecard on NCDs. So it's going to be generic, covering different NCDs, but obviously the cervical cancer was supposed to be part of the NCDs to cover. And when it comes to the Africa CDC approach, because we are at the continental, we are looking at the continental level, our indicators are that generic and they cover to make sure that all the countries can see themselves into our indicators. So what I wanted to mean is that we need to look at how can we work with ACHA to integrate, work together to integrate what we are doing and what you just presented, to just make sure we don't duplicate what is already there. Because it will be bad to have already an existing tool like the Aspire, and then we now develop something else on cervical cancer as well. So we need to work together to see how we can integrate the two
and support the work that we are doing. So for the NCD also, we are looking at integrating NCD surveillance, like developing the surveillance indicators for NCDs and at the continent level. But for the scorecard itself, it's a generic scorecard that's going to be covering different NCDs, not only cervical cancer. But I was saying it's good to see that ACHA has started with the cervical cancer, which can be a best approach to use as we are also moving forward, developing for additional, NCDs, but also which can be an opportunity for us to look on how we can, support the work that ACHA is already doing on cervical cancer, other than duplicating the efforts. I don't know if I answered the question, but that's what I will share around that question. Thank you.
Yes, thank you so much, Betty. There is a question for you, Dr. Nick, which is, Dr. Mishka has said, this is very exciting. Can you speak to how sustained and updated, and by whom? Thanks. Nick, would you like to attempt, or would you like me to speak into that?
Yeah. So sustainability is based on basically the players one, as our colleague from Africa CDC, I guess that is Betty, mentioned that I mean, the functions the cervical cancer function does not stand on its own. It stands with other health systems intervention. So sustainability is around reaching as much as possible to all stakeholders so that they speak from one voice, to have this as a standard scorecard for cervical cancer, to avoid duplication, or to avoid all the players in cervical cancer speaking from different positions. That is one. Two, the updating of the scorecard should be from the countries. There is an easy way where you can create an online form, basically similar to a Google form, for lack of a better word. And then the agreed indicators or data sets could be uploaded by respective countries using a consultative kind of process. The idea is to have the people who are answerable to actions that will improve cervical cancer, to eliminate cervical cancer, themselves feeling where they've succeeded and where they are yet to get good results, so that when now the red and the green is depicted, usually demonstrated to presidents or to the ministers of health or to ministers of finance, they can accept their reds, their greens, and their yellows. Over to you.
Thank you so much. And I want to also echo a little on that question from Mishka, to say that on this work that we're doing, first, to manage our expectations, what you're seeing right now is prototype data. This is data that was input by the consultant team together with the working group to be able to test the robustness of the tool and to see that it is working. Secondly, in January through to March, we will be going through a physical piloting of the tool within 3 countries. This is Kenya, Malawi, and Cameroon. And this is because those 3 countries were selected, one, because of the burden of the disease, second, because of the different stages at which each country is. Cameroon is already doing gender neutral vaccination. Malawi has a high comorbidity of HIV and cervical cancer. Kenya has all the 3 pillars already in place, but at this stage being implemented at different levels. And so we want to test the scorecard based on those 3 countries to see that the indicators are robust. But we will also be opening it up to scrutiny from yourselves. That is why we took the bold step to say, we can wait to be ready, but if we wait to be perfect, we may never reach perfection unless we have all our stakeholders also engaged. So you're on this call, one, to be sensitized about the ACHA scorecard, but secondly, to be invited as part of the team that will help us do scrutiny, to look at this document, to look at this tool, and to say, have you thought about this? Have you considered this other one? And so that as time goes by, and by the time we are presenting the actual prototype, the actual tool results, closer to March or April of next year, then we will have engaged in this consultative process. You'll have given your input. It will have been consolidated to make it better. And that comes to the other question that has been asked by Dr. Julie. Is there a feature where all the national indicators can be visualized together? And what, for example, what a country is doing well on versus less so? I think that I can ask Nick to give us how the reports will be generated so that the user is able to see at a glance all the indicators and ability to make the decisions based on the data presented. Go ahead, Nick.
Yes, and Betty has a hand up. Betty, is that an old hand or is it a new one? Maybe you can have the question asked after this. Yes, one of the iterations we have in mind is to have country-specific data sets available for the country. I had mentioned that though we have global data sets and indicators that are what do we call are measured and compared internationally, maybe or at Africa level. Some countries or almost all countries would like to see, for example, how subnational governments or regions compare districts, counties, provinces for the various countries, or even specific process indicators towards the bigger indicators that are being compared nationally. So the answer is with good iteration and especially getting this from users like you, we hope to have country-specific kind of indicators. I wonder whether Benda, was there any other part of the question other than availability of intra-country indicators on that?
Sustainability and robustness of data entry.
Yeah, so sustainability, I had spoken to this earlier. We envision a time where, first of all, we'll set rules on what kind of indicators will be collected. And then once that is done, uploading of data, we are envisioning it to be on a form, like the way you can fill a Google form or a Kobo form. But of course, with the limitations in terms of what can be input. Every data set or data unit has some rules to it. For example, some can be string values, others have to be other kind of values. Some can be sentences, other can be etc, etc, etc. And of course, quality checks across the same. So robustness will be advised by the amount of data or the kind of data to be collected. But I believe it's an easy thing to do because now with uploading online, you are able to restrict wrong data sets, but you are also able to involve as much data sets as possible to capture all countries and all data sets that will be agreeable to.
Thank you. Thank you so much, Nick, for that. Betty, did you have a question?
Yeah, yes, Brenda, I have a question and I wanted to confirm from your team. I'm sorry if I missed it maybe during the presentation, but I wanted to confirm, have you thought of a mechanism for the validation of these scorecards, mostly when it comes to the national level validation of the of the scorecard? Because if, for example, like this also translates to who does the data entry, because for in country it might be important for them to also agree at what is in their scorecard, like as per, I don't know whether it's the Ministry of Health or the data management institute of the country, but there should be a mechanism that ensures that what we have at the level of the country is something we can feel free to share and use across maybe even different countries for learning and support. So for that to happen, it has to be something that the country itself has consented to and said, yes, this data, reflects our reality, and this is where we fall in red or in blue, in green. So I just wanted to know, have you thought of a mechanism of validating the country level, scorecards at the national level?
Thank you so much, Betty, for that question. And the simple answer to this is it's work in progress. And that is why we are happy to have yourselves as Africa CDC, to have WHO Afro region represented, and various other potential partners to work with us. And even our current partners, I've seen we have representation from FIND as well as representation from Cancer Research UK. And why I say this is because a validation mechanism which will bring all actors in one space will require resourcing. And so working with yourselves, I have heard from you, Betty, I have heard from you, Dr. Dile, that we can work together towards resource mobilization to make some of these activities feasible. And so that if we're able to bring key decision makers on the table within the period of the piloting and after the piloting, within the uptake of the tool itself by other countries, then we will be able to say that it's owned by the countries. ACHA is just a repository of the knowledge. And also, it becomes a tool for benchmarking, because one of the things that we've struggled with as ACHA is recognizing that, for example, Rwanda started vaccinating in 2011. Some countries in Africa have not yet started vaccinating their girls. How do we measure the two countries and say both of them are on the same platform for measurement in terms of elimination? Therefore, we want to be able to say if, for example, the countries that have not yet started could cross-learn from the countries that are already doing gender neutral, or they're already doing HPV vaccination for their girls supported by Gavi and other partners, that cross-learning becomes an opportunity for countries to fast-track their movement, as opposed to struggling to try out alone and then not succeeding because the challenge of the late introduction was already working against them. So we're very open to that conversation, Betty. And yes, this is something that we're looking to see that even yourselves, when we are done with this call, we'll be sharing the report. And we'll also, within this week, we'll be sharing the report for the formulation of the scorecard. We'll also be sharing the tool itself. And we invite you to also circulate to the various partners that you work with, the various government agencies that you work with, so that we get as much feedback as possible on how we can make it better. That is part of our stakeholder engagement to make the tool more feasible for utilization and to ensure that there is buy-in on the utilization of this tool as a metric, as a collaborative tool, but also as a pulse on the a finger on the pulse of where are we at as Africa, what are we doing towards elimination, even for the countries that don't necessarily have the 90, 70, 90 in place, what are the other actions they are taking? For example, having an NCCP a strategy that then can be showcasing that cervical cancer is embedded as a tool for fundraising and resource mobilization for implementation of the work. And I've seen, Nick, you've also responded and said, yes, very valid question. A scorecard can only be effective if ministries and countries take ownership of the data uploading process, and strong validation is essential. So we have considered this, and we will need to document, led by each country, who is responsible for uploading data for their respective country. Thank you so much for that, Nick. I think we can say we are 3 minutes into the final moments of this conversation, but because we had some bit of technical challenges, I would ask if you would consider staying on for a few more minutes, even after the time has elapsed, so that we can have a conclusive closing of this meeting. Now, is there any burning question that we may have left out? And anybody who can raise their hand, will take just one or two more questions. Contact for more information, I'm posting on the chat right now, so that you can be able to write to us. And also, if you can get online for ACHA, you'll be able to get on our website and see all the other tools that I also presented, as well as this tool that we're working on right now. Those are the two emails. One goes to the larger team, the other one goes directly to me, and we will be able to respond to you. Venus, yes, your hand is up.
Thank you so much, Brenda, and the rest of the team for the presentations. I think my question is a follow-up to Betty's question. I think, because I'm actually need clarity as to whether this scorecard is something CSOs are going to use, for example, for a community-led monitoring exercise where they independently check those indicators, or we are saying countries are going to work with CSOs to upload this scorecard. And if that's the case, then who's going to own the data? Are there data sharing agreements, mechanisms for data sharing between countries? Because I understand that sometimes there is data that it's not, you can't just share country data. There's some sensitivities, some protocols when it comes to member states. So I wanted just clarity on that. Thank you.
Okay, thank you. Nick?
Yeah, so that was Venus. Yes, so Venus, I agree with you. If you work with regional, international government organizations, there are sensitivities, a lot of them, around what data can be shared and what cannot be shared. We experienced that during COVID, where some countries had to have very high level, president level kind of people to assent to data being shared, because data is very sensitive. It can have political or even economic kind of ramifications. So reading on my answer to Betty's earlier question, every country, every regional economic body must be comfortable before data is shared. So what data is being shared? Who shares this data? Who does this person share to? Must be agreeable to each and every other player, because eventually a scorecard is a marking scheme, sort of. You don't want to be, as a country or a subnational government or authority, you don't want to be marked or scored against an exam that you never took or you never agreed to, or a syllabus you've never been to school to. So everyone needs to be agreeable to how the data is collected, what data, who can view it before a scorecard can be finalized and before a scorecard can be used for advocacy. Back to you, Brenda.
Thank you. Thank you so much for that, Nick. So as we are coming towards the tail end of the conversation, I want to just raise a number of ways that you as participants on this call, as well as our various networks, can come on board to support. One, we have mentioned we will be having the pilots in the 3 countries, and we will be relying heavily on ACHA membership to sensitize their governments about this tool. But at the same time, the partners on the call to be able to help with the convening and support the in-country teams as we're doing the piloting in-country. This is where we will refine the indicators. We'll also refine the mechanism for inputting of the data, and we'll solidify ownership of the tool so that when it comes to actual implementation, then we know we have already worked with governments. ACHA already has experience in working with governments. We've supported the Côte d'Ivoire government in validation of the IEC materials and translation to French. and working with the government of Kenya in getting those materials ratified for us to be able to utilize them for across Africa. ACHA members are working with governments in South Africa, in Tanzania, in Malawi, in Zambia, and different other ACHA member countries. So this is a call to all of us to also support the piloting. Other ways you can partner with us is support in the convening power. For example, inviting various stakeholders on the table, or convening ability to support with some of the resources that are required in logistics to ensure we can bring the participants to the same locations. Technical input, we've already requested for yourselves to give technical input by looking at the tool even in its raw format right now to start thinking, how do we make it better? And we will be convening a technical bench that will work alongside the ACHA technical working group as well as the consultant team, sourced from yourself so that you can also be able to give us input on the robustness of the tool. We are in need of support in advocacy and resource mobilization. And this is not just resources in terms of funds. This is resources in terms of access to the different governments, access to the different key decision makers, and advocacy that this may be the tool that, as Betty mentioned earlier, and also as Dr. Dile has mentioned, can be one of the tools that will charge the lead towards cervical cancer elimination targets by 2030. Because we've already dug ourselves out of the hole, now it's to make sure that we are all sitting on the table, having a conversation around what needs to be measured for it to make sense. And lastly, we will be looking at capacity building of our members, as well as capacity building the various different country teams, so that we can all work together towards a commonality of goal. And so with that in mind, I am hopeful that with the email addresses that I've put on the chat, you will also be able to come on board, give your input, give your thoughts. No feedback is too small. Any feedback is welcome. We are appreciative of your time. Patricia, I've seen your comment. Would be helpful to consult RAMCA as well as ALMA Scorecard regional country teams, especially around the governance and data sharing requirements. Thank you. And we'll take that into account as we go into the next phase of the scorecard. Now I'm handing over to Maud. Maud, and we do have some of the representatives from our partners. Anyone else would like to make a comment? Ayla, Pauline?
Nothing from me, Benda, but it was great to see this launch, and yeah, very excited to continue supporting the work that ACHA and Kaleli are doing.
Thank you so much, Ayla. That's Ayla from Cancer Research UK. Pauline, are you on the call? Okay. Over to you, Maud.
Okay, thank
we
you
also have
very
Dr.
much.
JP from the Ministry of Health in Kenya. Dr. JP, do you have any comments or any thoughts into this?
Thank you, Benda. And thank you everybody on the call. I think I am just absorbing the what I've listened to today and what I've learned. And I think this is a great initiative. We'll continue to think through and see if there's any comments that we can give. Thank you.
Thank you so much. Over to you, Maud.
This actually marks the end of the meeting that we had today, and it was a very rich conversation which you've had, and the participation was really good. So what I'd like to do is actually thank all our presenters, that is Betty, Dr. Dile, Nick, Benda, yourself, Dr. Robinson, for all the presentations you did, and also to acknowledge our partners, that's Sierra UK, Find, and Clearly Health. Also acknowledge other partners like United and Expertise. and also to look at the opportunities which CDC and WHO have extended to us. And I think you've already talked about that, Brenda, at quite extensively. So we want to thank you, and mostly want to thank each and one of you who has attended this meeting. Thank you for taking your time. We wouldn't have had this meeting without you. So let us continue working until cervical cancer is no longer a threat to our mothers, to our sisters, and to our daughters. We are sure, I think in the chat, there's a link which has been shared on the scorecard link. You can look at that, and we just hope that the secretariat will be able to send the same link to your emails which you have shared with us. So thank you very much for your participation. Have a great afternoon and a great evening. Thank you very much, and bye-bye.
Thank you.
Thank you, everyone. And thank you, Dr. Dilep. Thank you, Betty. Thank you, everyone,
Thank
for
you
your
all.
contributions.
Have a good evening.
Thank you,
Thank you,
team.
everyone.
Great
Bye bye.
presentation.
Bye. Thank you.
Thank you.